So my talk is going to be on third phalangeal cysts in the Thoroughbred Racehorse. So subchondral bone cysts, or probably what they're more recently and more accurately termed are osteocyst-like lesions, can affect multiple sites in the equine skeleton, including the radius, the carpal bones, tarsal bones, and metacarpal and metatarsal bones. However, two of the most common locations where they're seen are the medial femoral condyle, which we heard from Debbie this morning, and the distal phalanx. The pathogenesis, despite quite a lot of research, is still quite poorly understood. We know it's most likely to be multifactorial, and whether it's a developmental disorder with failure of endochondral ossification, or it's also been hypothesized that it's due to trauma with either focal sepsis and or ischemia. So looking at the pathogenesis of these cyst-like lesions in a bit more detail, it's suggested that failure of endochondral ossification causes retained areas of cartilage within the developing bone, and that these areas are susceptible to injury, causing osteochondral clefts and fragmentation. This hypothesis is probably most relevant to the juvenile thoroughbred, and it's also been seen in the young human. However, osteochondrosis does not explain the occurrence of these cyst-like lesions in older horses, and researchers have been able to induce subchondral bone cysts with cartilage or subchondral defects alone, suggesting that traumatic bone injury, either single or multiple areas of trauma, could be responsible for cyst development. So why are these relevant to the thoroughbred? Primarily, they can cause lameness, and which is thought to be the result of either synovitis and increased intracystic or intraosseous pressure, leading to bone pain and edema. We know from clinical experience and from research that a lot of these osteocyst-like lesions can be asymptomatic. However, they can cause significant wastage, financial loss, and primarily it's a welfare issue for welfare concern to have these horses quite lame as young thoroughbreds. They're also quite relevant because we often don't know quite what to advise our clients and what to do with them. The present therapies for subchondral bone cysts are very varied, from rest to intralesional injections to arthroscopic nucleation and debridement to putting lag screws across medial femoral condyle cysts. Some are very invasive, some are very conservative, and the success rates are quite variable from different management strategies adopted. These cyst-like lesions present many challenges to the veterinary surgeon. As Debbie spoke earlier, looking at radiographic findings in terms of sales, these cyst-like lesions, not just in the distal phalanx, but particularly in the stifle, but in other areas, they cause great concern, particularly when they're found in young foals, yearlings, and 2-year-olds, to either the breeders who own them, vets offering advice to prospective purchasers, or when you're in the scenario where the horse is in training, offering advice to owners and trainers with clinical cases. How do we diagnose them? Primarily to locate the site of lameness, we're using diagnostic anesthesia. First line imaging modality still remains radiography for identifying these cyst-like lesions. There is an Eve paper published by Mayer and Sherlock in 2007, which demonstrated that many of these cyst-like lesions were difficult to detect by radiography alone. We'll discuss that a little later in more detail. And obviously the gold standard, particularly when it comes to distal phalanx, is to use low or high field MRI is probably the gold standard imaging modality for that area. So as Celia said, we published a small study on this last year, and the reason I'm speaking about it today is because of the study and because of a personal clinical experience. So I was looking after a horse, a 2-year-old horse in training, who had come through a breeze of preparation, was sold as a breeze of horse in training sale. He ran 6 weeks after the sale and finished second. About 2 weeks after he ran, he did his first bit of fast work after the race, and he had a third tarsal bone slab fracture of his right hock. as an aside, following discussions with the different connections, it was decided to manage this conservatively, and the horse had 6 weeks. It was advised to give the horse 6 weeks box rest. On the 2 days before he was due to be reviewed, and he was due to be reassessed and repeat radiographs taken before he started walking exercise, I got a phone call saying that he was fracture lame on his other leg. He had quite increased digital pulses and a very warm foot, and quite obvious clinical signs showing that it was the foot was a site of pain. He had a positive response to palmar digital nerve block. I presumed he was quite a strong, boisterous colt, that he had kicked a wall or done something silly in the box while he was undergoing box rest, and took some radiographs and saw quite a large P3 cyst. So the trainer asked me what this meant in terms of future racing prognosis, what should he tell his owner, and what the rehab and what should we do about this, or whether we should do further imaging. So I spoke to my colleagues, and I did a little bit of research and read about the area and read about the subject, and the information given was quite mixed. Most of my colleagues were sort of anecdotally quite negative on pedal bone cysts. The literature was quite unclear. Most of the previous studies are based on very small numbers or on non-thoroughbreds. The study I mentioned earlier by Mayer and Sherlock, the follow-up, it was mostly an imaging study, rather the follow-up information was based only on one horse. The racing performance has been looked at, but only after surgical management, and again in very small numbers. And little information is known on the treatment or management and outcome of cyst-like lesions in locations other than the medial femoral condyle. And a lot of the surgery-orientated research was done on older horses with the follow-up was a little bit sketchy. So thankfully here we're lucky enough to be on the doorstep of a very large thoroughbred population training here in Newmarket, and our referral centre sees a large thoroughbred population for both lameness examinations. So we aim to assess the racing performance of thoroughbred horses presented for lameness localised to the foot with a radiographic diagnosis of a cyst-like lesion, which is managed with rest or medically. So none of these horses were managed surgically. So we believe that it will be that these lame thoroughbred horses with a cyst-like lesion in the distal phalanx will be less likely to race than their maternal siblings. And secondly, then we hypothesise that potentially these affected horses will be less successful than their maternal siblings. So in our study, we looked at over a 10-year period of our clinical database here in the practice, and we included thoroughbred horses with 4 hind limb lameness that had a cyst-like lesion affecting P3, which was diagnosed on radiographs. All these horses had lameness localized to the foot by either a positive response to a coffin joint block, a PD nerve block, or an abaxial cervical nerve block, which also had a negative response to intra-articular diagnostic anesthesia of the fetlock joint. We collected the data and included the sex, the age at the time of detection, how lame the horse was, which limit was, and what treatment was used. The treatments used in these horses were only a very short, very small amount. So they were either box rested on controlled walking exercise only, the use of triamcinolone and hyaluronic acid, corticosteroids alone, or a couple of horses were managed with regenerative therapies such as platelet-rich plasma. And all these treatments were aimed, the idea was to reduce local inflammation and promote bone and cartilage healing. So 2 specialists in imaging reviewed the radiographs, and they looked at the number of cyst-like lesions within the pedal bone, the size in millimeters, where the cyst was located, whether it was sagittal, lateral, or medial, and the presence of sclerotic rim or not, or the presence of an irregular articular surface on the articular surface of the distal phalanx in proximity to the osteocyst-like lesion. From a non-imaging specialist, whether the cyst had a neck or not that communicated with the joint. And we also looked at whether the lesion could be detectable on lateral or oblique projections as an indentation of the articular surface of P3, and then when these indentations were noted, whether they were found on the dorsal medial or palmar plantar aspect of the joint. We also considered whether there were other radiographic changes associated in the adjacent structures, such as the presence of an antesiophyte formation at the dorsal distal aspect of the middle phalanx, osteophyte formation affecting the cuff joint, or an increased soft tissue opacity dorsal to the DIP joint. So we crunched the numbers and looked at and we performed regression analysis in the group of maternal siblings to allow for a clustering of the data by dam. And we looked at the following factors to assess for any associations with the outcome of racing or not racing. So whether age at the time of detection, the sex, the affected limb, whether it was a front leg or hind leg, how lame the horse was, and the features of the cyst-like lesions, and whether this affected the likely outcome or not. If the horse raced, the highest racing post rating achieved by that horse was compared with compared to his maternal siblings, and we calculated odds ratios with 95% confidence intervals and continuous variables such as the age at the time of detection and the racing post rating achieved were assessed using a Shapiro-Wilks test. So what do we find? During this 10-year period, 20,056 thoroughbred horses were presented for lameness evaluation. So we had 22 cases that met the inclusion criteria, equally spread between male and female, and quite an even enough distribution between 2 foals, 8 yearlings, 9 2-year-olds, and 2 horses over 4. This probably tallies as well with this subset of horses that we're seeing here, the juvenile flat thoroughbred horses. The cyst-like lesions were seen in the forelimb of 17 of the 22 horses. This correlates quite well with the previous study done by Mayer and Sherlock, which they saw the cyst-like lesions in 11 out of 12 of the front feet that they looked at. Interestingly, we know that these lesions are asymptomatic in other sites, particularly the stifle, and it's sort of unclear whether they're asymptomatic in the distal phalanx. However, in this study, we had 2 horses which had cysts-like lesions identified in the distal phalanx, both in hind limbs, in the contralateral non-lame limb as well. So we gathered the data. There are 23 horses here. One was excluded from the study because the horse underwent arthroscopy, but we looked at the age, the time of detection, whether it was visible on the lateral medial projection, the location of it, the limb, the treatment used, the lameness grade, and whether they raced after detection of the cyst or not, and the different blocks used. The location of the cyst-like lesions within the distal phalanx, they were located sagittally in 16 cases, lateral to the sagittal plane in 2, and medial in 4. In 8 of the cases, there was an indentation in the articular surface of the distal phalanx, which could be seen in a view other than the dorsopalmar view. There was a sclerotic rim noted in 19 of the 22 cases, and we grouped the cyst-like lesions in 2 groups, either smaller than 1 centimeter or larger than 1 centimeter. The treatment used with these horses was, as mentioned previously, 4 of the horses were medicated with triamcinolone alone, 4 of the horses were medicated with PRP alone, and 12 of the cases were medicated with steroids or with triamcinolone and hyaluronic acid. The follow-up from going back 10 years, but the advice was given to these horses was they all underwent 1 month of box stress followed by 2 months of walking exercise. Retrospectively, it's slightly difficult to assess the client compliance with this, but that was the advice given at the time of detection of the cyst-like lesion. 2 cases were not treated with any intra-articular medication, and the only difference here, they were given 1 month extra of box rest. So of our 22 horses, 8 did not start a race after the detection of a cyst-like lesion, 13 raced at least once. 1 case, as of the time of publication, had not reached racing age. We identified 141 maternal siblings, with 119 of those racing at least once. So there was quite a significant percentage difference between horses with a cyst-like lesion that raced and those that with the affected horse that raced and the control group. So the horses were less likely to race after detection of lameness and an osteocyst-like lesion than their maternal siblings. The only variable, or the only factor which of all those of either age at the time of detection, whether it was a forelimb or hind limb, the sex of the horse, how lame the horse was, that appeared that had a significant had a significant relationship with the outcome was whether, in our study, horses with an osteocyst-like lesion affecting their left frontal limb were 2 times more likely to race than a cyst-like lesion affecting any other limb. This was quite surprising, and I think it's quite dangerous to read too much into it. I think this is most likely a result based out of a very small subset of horses. I think it probably, if you were to find a subset, find this result potentially in the US or in a racing jurisdiction where they always ran the same direction or always trained the same direction, you could possibly explain it. But these horses are all trained and raced in straight lines, and I think further research is needed, but I think it's unlikely that this finding will be validated in a larger group of horses. Looking at how these horses performed, there was no significant difference between any treatment used versus and the positive outcome for racing. The highest racing post rating achieved for horses with a cyst-like lesion ranged from 41 to 131, and the same with a mean of 78.7 and a very similar mean for the maternal siblings. So there was no significant difference between the highest racing post rating achieved for the affected horses and their maternal siblings. So, in summary, our first hypothesis that the affected horse will be less likely to race than their maternal siblings was true. But our second hypothesis was proven to be false, that these affected horses were performed no differently than their maternal siblings. So as mentioned previously, there are some limitations of radiography. We know that from various conditions, but in particular to the equine digit. The Mayer and Sherlock study in 2007 highlighted this, and they looked very closely at the MRI, use of MRI to identify these lesions. Bone mineral density was changed by approximately 30 to 50% before lesions are visible on radiographs. So probably when costs allow and when facilities are there, either using CT or low or high field MRI when appropriate is a more sensitive tool. But I think obviously it depends on the circumstances and depends on the economic wishes and the clinical presentation of these horses. So what can we conclude from this small study? That primarily, I think the first point is that this is the osteocyst-like lesions causing lameness in the thoroughbred are a very rare cause of lameness. From 20,000 roughly 20,000 exams, we have 22 horses that we could find over a 10-year period that fitted into this study. Affected horses are about 3 times less likely to race than their maternal siblings. I think this is valuable for vets in clinical practice that are presented with cysts of the distal phalanx, either at foal, yearling, or 2-year-old stage, particularly for at the stage before they enter training. I think it offers a little bit of guidance that vets can offer to their clients, and when faced with this lesion. I think we can advise breeders that if they are forced to hold on to these horses, that they can't sell them because of the cyst-like lesions, that if they do make the racetrack, they will perform similar to their siblings. Interestingly, there was no association between grade of lameness or actually age of detection and the outcome. And it's probably a debate for another day, but we don't, because radiographs of thoroughbred feet are not included in routine juvenile thoroughbred pre-purchase examinations at foal or yearling stage, we do include a lateral and DP projection in the Hong Kong vetting protocol of the front feet, but our knowledge of the true prevalence of osteocyst-like lesions in the P3 is unknown. It was always thought that they were unlikely to be asymptomatic, and that possibly still is the case, but it probably warrants some further research in a large group of horses to assess the true prevalence of these cyst-like lesions. We don't see them very often in these Hong Kong surveys, but these horses are probably not a true reflection of the overall population. These are usually elite race horses that have been selected for purchase, and they were probably excluding quite a lot of the population. And finally, just most of the previous research is proposes that the surgical enucleation and debridement of these cyst-like lesions is the best approach to take. Barring general anesthesia and the cost of surgery, one of the main issues obviously is surgical access for these lesions. One previous study published had a very high success rate of return to racing following surgical debridement, but again it was only a very small amount of horses, with 9 horses, with 7 of them returning to racing. So I think if the cyst if a surgeon is confident that they can access the cyst and debride it, I think it is definitely, from the basis of the research, it definitely warrants consideration with your clients. But I think if it is not accessible and it's not economically viable to operate on these horses, I think it is shown that quite a few of them can go and race successfully, even with a cyst being identified. So just finally, I'd like to thank my colleagues that helped with this short paper, Vanessa Peter, Lewis Smith, and Daniela Schweitzer-Gorges from the University of Bern, and also the treating veterinary surgeons at Rosedales who provided the cases. Thank you very much, and is there anyone?